By training, I'm a general internist and addiction medicine specialist, and I think my residency training really coincided with the opioid overdose epidemic. So I did all my training in Baltimore, and really during that time, fentanyl, replaced heroin in the drug supply, and the patient outcomes that I was seeing were just terrible. Felt unrelenting at times, seeing the impact of alcohol and other drug use in the hospital and in clinics. Usually if a patient was presenting to the hospital or for a new issue in primary care, if their primary issue wasn't related to substance use, peeling back the onion a little bit, substance use was at least contributing in some way to whatever health condition that they had, whether that's tobacco, alcohol, or other drug use impacting their ability to adhere to medications for diabetes or directly impacting high blood pressure. So it seemed like there was just like always an undercurrent of substance use that was being kind of contributing and maybe not even being addressed in our healthcare system. So that kind of seeing that and like trying to understand why are we not addressing it in the hospital, and now why are we not addressing it in primary care? What is the evidence that we need to bring treatment to the people who are affected? Kind of became a passion and a career trajectory for me. Buprenorphine is the most highly prescribed medication for opioid use disorder in the United States. It's available by primary care doctors outside of kind of traditional treatment settings that can be picked up by prescription from any CVS or pharmacy, just like every other medicine. Despite that, fewer than 1 in 5 people with opioid use disorder receive a medication for opioid use disorder. Our system still fails them, and so patients and people who use drugs, they don't want to wait around for us. They don't want to wait around for a primary care visit in 2, 3, 4, 6 weeks. They want treatment now. And so buprenorphine, diverted buprenorphine, that's medication that is given to a friend, family member, or bought on the street, has been emerging among people who use drugs as a way for them to kind of treat themselves or to get the therapeutic benefit of buprenorphine, but not through a traditional treatment setting. That is really important to note, because that is maybe a reason why we should advocate for it being available without a prescription behind the counter. That is, anybody could go to a pharmacy and get it. The limitation is that the studies so far really have been done in small areas among people who are already seeking treatment. So it might just be that they're more inclined to use it in a therapeutic manner. So what the PhRMA Foundation grant is allowing me to do is actually reach people who are not currently in treatment, those people who might be using drugs but are not actually trying to get help, and seeing if buprenorphine is being used in the same therapeutic manner. And it'll answer this important question of should buprenorphine be deregulated even further to be allowed to be available behind the counter without a prescription. So it fills a really important gap in our knowledge around how non-prescribed, quote-unquote, diverted buprenorphine is being used in the community. I would like to be an independently funded clinician investigator focusing on patient-centered addiction treatment and demonstrating effective strategies to deliver evidence-based interventions that meet patients where they are. I think the best advice I ever had is, when you're setting personal goals, set goals for rejections, because it's going to be a part of the process. Because then all of a sudden every single rejection helps you reach that goal. And really that comes back to persistence just pays off.